Ooh, 1,100 people. I think it's time to start talking. Guys, it's Easter. This is the day where the millions around the world celebrate the fact that Jesus was full code, as opposed to do not resurrect. You'll notice today on Against Medical Advice, we're going to be talking about rudeness, medical culture, and how rudeness can kill in the hospital. But I want you to note I'm missing two what I thought were very important people, but it turns out they're expendable. And I've replaced them on this family day with...
Hello, everyone.
Mrs. Frickin' Dog.
Happy Easter.
MD. That's right, people. It's Mrs. Dog. And she is running the board. You want to switch me back to camera one? There we go. She's basically doing Logan and Tom's job combined, okay? Now here's switch back to your camera. I want to tell them about Mrs. Dog, okay? Because Mrs. Dog has never before really been seen on camera for a variety of reasons that we'll get into in another episode, mostly having to do with being an autonomous individual who wants her privacy. However, given that Logan had family over for Easter and Tom is in Zion doing gosh knows what, she said, you know what, to save this family, I'm going to step up and I'm going to do both of those lazy millennials jobs and be a medical consultant, because she is a Stanford trained and practicing radiologist in chest radiology, still goes out to Stanford and does teleradiology.
Yeah, well, someone has to step up when you have lazy millennials working for you. And that, yes, I am talking to you, Tom and Logan. You're not getting any homemade brownies from me anymore. No.
Oh man, you know, you used a word with Tom and Logan that I want to just point out, and that was working. And I think working and those two, I don't know that it goes together, honestly, Mrs. Dog.
Well, you know, I shouldn't have combined lazy and millennials together, because in fairness, not all millennials are lazy, just your millennials.
Hey, don't tag me with them, all right? But guys, so check it out. Mrs. Dog has graciously, and the kids, by the way, the Z-Pups are downstairs doing I don't know what. The youngest one had a meltdown right before we went live. Mrs. Dog was comforting her, getting tears all over her dress, because the oldest one had given her a look, just like this. And it was enough that the young one burst into tears. So we're hoping that this is going to hold, because I want to talk about something important, which is a New York Times article that was written by a pediatrician, Dr. Perry Klass, about how rudeness exists in healthcare circles, what it does to doctors, patients, nurses, staff, etc. Does it affect the quality of care? Do people die as a result of rudeness? And I was talking to Mrs. Dog about it, and we both trained together at Stanford in internal medicine, and then she saw the light and retrained in radiology. I stayed in medicine. We've both encountered the culture of medicine. So we said, you know, there's a lot to talk about here. I'm going to read a couple comments before we start, just to get it happening. Lynn Comer, radiologists are amazing and brilliant. Apparently, Mrs. Dog would agree, or would you? Are your colleagues amazing and brilliant?
Many of my colleagues are amazing and brilliant.
Are you just saying that, or is it a thing?
Well, you know, radiologists, they have to know a lot of things.
Christian Castile says, Narcan brought Jesus back to life, FYI. Harm reduction works, people. Thank you for that Easter pearl. I really do believe that if he do not resurrect, we would have a very different world right now. And it would be a much less fun Easter. Dawn Dixon says, she is beautiful. I assume you're talking about me? Because of my whole gender identity. Oh dear. So anyway, Anne Reeb, Z did marry up.
By the way, that's the usual look that he gets from me whenever he makes a comment, or really any comment, whenever he opens his mouth.
That's my responding look. It's usually, we've been married for how long? When did we get married? 2002. Too long. That's racist. That's just right. It's because I'm off-white that you're saying that. We got married in 2002 after we met, in 99?
2003.
Oh, crap. It seems like it's been a year longer because we were so in love for that year before we... Oh, all right. Well, anyways, let's dig into this whole thing.
I love you, but I'm not in love with you. I'm just kidding.
Don't make me pull off my titanium ring that I bought for literally $50 from a Canadian website because I lost my platinum ring during our honeymoon in Maui. It literally fell off like Gollum like in the river Anduin and got lost to follow up. All
Okay,
right, guys.
We need to get back on topic.
Back on topic. Here we go. We're talking about rudeness. Now, this article, Rude Doctors, Rude Nurses and Rude Patients by Perry Klass, actually cites a study that was done earlier on rudeness, a couple of studies that were done earlier. And the studies basically say this. They took in Israel, they took a simulated environment with neonatal intensive care staff, so physicians who work in the NICU basically. These are very highly trained, very complex environment, critical care environment where there is a lot of not just muscle memory and intellectual memory, but very high level complex thinking, life and death situations, et cetera. And they said, okay, what happens to teamwork, which is a crucial piece of a critically complex system like that, and individual decision making in the setting of rudeness? In other words, a simulated patient, their set of actors, was loudly overheard by teams saying something disparaging about the care or the hospital. Like, boy, you know, next time I'm going to go to a hospital, it doesn't behave like it's in the third world, or something really nasty like that. So those of us in healthcare, those of us who are patients, we've all encountered rudeness across the board in healthcare. It's just something that seems to be par for the course. But the question is, does it affect us? We're supposed to be professionals. We're supposed to be above these sort of petty insults and slights and those kind of things. But what they found was when the staff encountered this, for the rest of the day, when they were doing high-level complex activities in the simulation lab, they did worse. They made worse decisions. Their teamwork was less cohesive. Everything pretty much fell apart a notch compared to those who were not insulted. And so what does that say? Are they consciously, so when patients read the article initially, a lot of them commented and saying, well, the doctors are just retributing because they feel insulted, and so they're like, we're going to give worse care. Hey, guys in healthcare, does that actually happen? No. We would never consciously retribute, especially NICU patients. Like you're gonna I mean, are you really going to take vengeance for a rude comment of a parent on a premature child, even subconsciously?
I wouldn't think so. I mean, I think we're all trying to do our best in every situation for every patient, you know, regardless of what parents are yelling at you, or even what a patient is yelling at you. You still are trying to do your best for that person.
So what then is going on when the staff are doing worse and the outcomes are presumably worse? What do you think is happening?
Well, you know, I think that that when someone makes a rude comment, you know, the person who's on the receiving end is going to internalize that negativity. And so, you know, for me, I would start thinking, God, what a rude person that was, and maybe he's right, maybe I'm a horrible doctor, you know, but you're still thinking about all those negative things, and so you're not really focused on the task or the patient or the problem in front of you.
And I would take it a step further. I think that's true. I think there's conscious reliving of the comment. For example, when I used to take call a lot as a hospitalist, every now and again I'll have a patient who will directly insult me or be really rude or be disparaging or say something about the care or say something to the nurses or another member of the team about me and the care. And what happens is I'm reliving it constantly and getting angry and getting defensive internally. And I'll go home and try to get a little bit of sleep before my next phone call or admission, or I'll be in the call room and I can't sleep because I'm just reliving this thing. And ultimately I think it comes from a bit of defensiveness, a bit of it, could they be right? And then a bit of anger and a bit of trying to figure out, well, how can I, you know, what did I do that was so wrong? And this patient, all the reasons why they were wrong and so on. And that kind of rumination takes processor cycles from actually thinking about taking care of patients. So that's a conscious disruption of, and I'm going to go back to this metaphor that I use a lot. Now let me explain it real quick for people who are new to the podcast. The idea, and it's John Haidt, psychology professor, I think it's pronounced Haidt actually because hate is a little bit strong. He has this analogy that we're all these big elephants, these unconscious emotional intuitive processors that are, you know, hope and fear and threat detection based, and that's our primitive brain, and that's what makes the decisions. And then we have this little guy riding on that elephant that is our conscious strategizer, our thinker. And contrary to popular belief, that thinker doesn't run the show. He's a tiny little guy riding on a big elephant. He is the press secretary.
For you, it's especially tiny.
You know, the use of the word tiny and me in the same sentence is first of all, talk about internalizing offense, all right? Now I can't even do the show because I'm so upset. Back on track with the little guy, I mean the huge guy on an even huger elephant. Mrs. Dog, because it's all about size does matter. The little guy is really a slave to this elephant and actually is the press secretary or the lawyer for the elephant. So the elephant makes an unconscious decision and the lawyer just backs it up with reason. That's why it's very hard to reason with an anti-vaxxer. It's very hard to argue about religion and politics because people's elephants are making these decisions and their press secretary is just acting in accord with the elephant. Now, what I think happens with rudeness is the elephant is undermined. The unconscious processor detects threat. Oh my gosh, this person doesn't like me, this person doesn't think I'm good enough, maybe I'm not good enough. Fear cycles unconsciously, and the press secretary starts spinning stories to try to explain it away. And it's so busy doing that, and the elephant is so busy in threat mode that there's less bandwidth. Remember, we're humans, right? There's less bandwidth to do complex decision making, healthcare, taking care of actual patients, including NICU babies who are the most vulnerable of the vulnerable. So that's my take on maybe why they saw this result. Now, what's interesting in the original study from Israel, by the way, there's been some talk in the article in the New York Times. They were talking about, well, it's interesting because Israelis as a culture are known to be very forthright. In other words, and some other people will call it rude, but Israelis just know, they just say what's on their mind. And so there's even a higher set point potentially culturally. This was speculated in the article, I can't speak to it. There's a higher set point culturally to rudeness and an insult. So
but don't you think there is a difference between being direct and being rude?
So it's all in the perception in my mind. Like, for example, I was raised on the East Coast till I was 8. I had a certain level of being forthright. And I grew up around a lot of friends that were just, this is what they just said what was on their mind. You move to California, everybody couches everything in, oh yeah, no, and they're all nice and they never say what they mean because they're trying to be polite and smooth things over. Now, if I go back to the East Coast, I always feel like, man, these folks are rude. But really all they're doing is saying what they think. And so the question is, it is in the eye of the beholder, but when you're in a healthcare setting and you're feeling vulnerable and you're scared or whatever, defensive, then I think the set point for perceiving rudeness changes. And I think that's partly what they were saying. Is like, even though Israelis may have a higher set point for being blunt, they still saw an effect in this trial because it was done on Israeli physicians. And so the question is, the thought is that this is a real effect. Now, they did 2 interventions to try to see if they could ameliorate the negative impact of rudeness bestowed by patients upon the healthcare team to see if they could improve functioning, cognitive functioning. One was after the fact, so after the insult, later that night, they were told to write down a story from the perspective of the mother who was being rude. So in other words, the way I interpret this is they are trying to use empathy with the mother. So in other words, let's put ourselves in her shoes, feel her pain, feel how scared she was, feel how nervous she was, and see why she might have reacted. Do you know what they found in that intervention arm? No improvement in cognitive function, and in fact, there was some tendency to do worse for even longer. And this gets back to Against Medical Advice we did a couple episodes ago where I talked about empathy being bad relative to compassion. Empathy being feeling someone's pain and acting on that feeling. Compassion being love, unconditional love in a detached way in the face of suffering. Now, if you love that mom in the face of suffering, you recognize she's rude, but you don't take it personally because you understand she's suffering and you love her for it. If you try to use empathy by writing this story, you put yourself in her mind, you feel this anger and this pain at the doctor, and now you go back to being the doctor and you're like, man, I am kind of like rude, I am kind of like not the sharpest tool in the shed, and it gets worse, right? So it can be a very bad thing. Now, the intervention that showed some improvement, a tendency to improve cognition, was a cognitive behavioral modification where they played a video game that's used with people who suffer from PTSD. And the idea is you look at faces that are angry, and the idea is to desensitize, if I'm understanding this correctly, and raise your threshold to detecting threat. So in PTSD, the threat detection threshold is dropped so that everything is a threat and you're always on edge. Well, the idea is that let's raise our butthurt tolerance so we don't get easily butthurt by rudeness. And that actually did show some effect. So it shows that even though you are affected by rudeness, you might deny that you're affected by rudeness, but honestly, the evidence shows your elephant, your unconscious, is affected. It is affecting you cognitively. If you can practice these techniques, you might be able to immunize yourself somewhat in a professional way from the effects of rudeness. And this was a fascinating idea. And again, that's why I think human psychology is the great frontier that we need to understand better in order to do medicine better.
Well,
what do you think?
I think that's an important point in terms of not taking rude comments personally. And I think several of the commenters have also said that, including Melanie Rockwell. When someone makes a rude comment, it can't be taken personally. What is the core of the rudeness? But I think that it's probably harder for some people to do than others. So, for example, I tend to internalize rude or negative comments, and I kind of direct that negativity towards myself and think, well, what did I do wrong, and why is this person making such a rude comment? I must be in the wrong. Whereas someone like you tends to externalize things, and maybe you actually would deal with rudeness better than me.
I'm so hurt right now. I don't even know where to begin. No, but it is true. She's actually right. If I'm being completely honest, the way I deal with rudeness is I externalize it and I try to project out, and that's why I use humor a lot. So in the hospital setting, if a patient is rude, I might make a joke, I might do something to try to diffuse it, to externalize it. My wife might internalize it and try to process it that way. So everybody processes it differently, but telling people, oh, walk it off and man up, it's very hard to do. It takes practice and training, and actually an acceptance and a bit of vulnerability too, to understand that we're not perfect, that these things do affect us. And I think that's part of the problem in hospital cultures. Vulnerability is not okay. It's never okay to be like, you know what, I'm not perfect, I'm affected by these things, I have cognitive bias, I make mistakes, especially when you're attending or your senior resident or the nurse who's training you, because nurses are notorious for a culture of eating young. Not always, especially in a group of people that are so high in empathy, but they're known, at least if you hang out with nurses enough, this idea of eating young is a cultural edict in hospital training. And so in those settings, showing vulnerability, showing weakness of any kind is considered bad. But the idea that you have to carry yourself with confidence and always have your shields up is a cultural expectation, it seems like to me, in healthcare. Now, what's interesting is, there was a British study in 2015 that was called Sticks and Stones. And they actually came up with an acronym for the kind of abusive behavior that happens in the medical hierarchy, where doctors, medical students, nurses are rude to each other. And they called it RDA, or rude, dismissive, aggressive behavior. And of course, everything's a frickin' acronym in healthcare. So the RDA stuff, 31% of healthcare practitioners said they experienced it often in the course of a week. And the question is, what they found, what's interesting is, and this is what I thought was fascinating, they found that it was more common in certain medical specialties. Well, first of all, it was more common to be abused in younger, less senior people, duh, right? We eat our young. But it was more common in certain medical specialties. General surgery, duh. Neurosurgery, interesting. Cardiology, and number one, radiology. Radiology. Now, I understand, because when I asked if you would help me with the show, I actually begged, and I might have actually cried a little bit. Mrs. Dogg, I said, do you want to help me do this because Tom and Logan are losers? She said, well, I know they're losers, but no, I've told you I don't really want to be on camera, but what's it about? And I said, it's about rudeness. And then she told me this story. And here's the thing. Mrs. Dogg does teleradiology now from home, and then also flies back to Stanford and does shifts with the academic chest guys. She is one of the most beloved radiologists on the phone to consultant ER docs around the country who she deals with at night, and to the raid techs and to people that she talks to. She consistently gets this feedback. Now the question is, why are you so nice? What happened? Well, because I'll tell you, I don't get that at home. All right.
Okay, you don't deserve that.
Wow. Wow. People are like,
that
Z-Dog.
has to be earned.
Z-Dog, how do you stay grounded? You're looking at it. Okay.
RDA communication. That's our marriage.
That was I think our vows were RDA. It was like, I hereby solemnly swear to be rude, dismissive, and aggressive at any point that I can.
And he's good at keeping his vows.
That is rude and dismissive and aggressive. Anyway, so tell the story about what happened with you in rudeness.
Well, sadly, I wasn't always so nice on the phone. So I remember during my training as a radiology resident, I was on night float, and they were like 12 or 14-hour shifts, and you were the only radiology resident for 3 hospitals. And so this was my first week or two of night float, and by the end of the week, I was extremely tired and getting very grumpy. And as Zubin can attest, when I get tired, I get extremely irritable. So I'm cutting back to me since I'm in control.
She controls the board.
No more cutting back to you. So a poor general surgery intern came down around midnight and asked to see some thyroid nodules. When I was trying to look at a head CT to figure out if a patient had a head bleed, and I lost it on that poor general surgery intern. And so,
which, by the way, just goes to show that the gradient of rudeness still goes radiology, general surgery. All right, just understand that. Please continue.
So the general surgery intern left, and I sat there and I felt like a horrible, horrible person. And I came to the realization that my being rude and going off on people really wasn't helping anyone. It certainly wasn't helping the people around me, and it wasn't helping me feel better either. So I recall making a very conscious decision at that very moment that I was just going to be nice. And if I couldn't be nice, I would be at least polite. If I couldn't be polite, I'd be civil. So I've carried that with me for the entire rest of my training and work life. And I found that really, if you're nice, then people will be nice in general, except for the general surgeons back. And they're going to be more receptive to what you have to say anyway. And I think that it elevates the entire mood and way that people work. So I try to be very cheerful, and if we can get a laugh together at night, everybody's just trying to do their best, then that's what I do.
Yeah, I'm pretty lucky to be married to this woman because she actually pulled that off. Like a lot of people make these resolutions, I'm going to be nicer, and then they fall back into their elephant ways, right? But she actually does do this. I hear her on the phone, and I'm like, who are you talking to? It's like your best friend in the world. Oh, it's an ER doc. I'm like, what? Immediately, as a hospitalist, I get my hackles up. I'm like, they're going to admit to me. But that's actually not true because, honestly, I had a similar epiphany when, and for me, again, this is one of those things where empathy became a tool that helped me. So by doing emergency now remember, I'm a hospitalist. People keep thinking I'm an emergency doctor because I'm cool as heck and I'm extreme. Actually, I'm neither. There it is. There's the eye roll. People keep thinking I'm an emergency doc, but I'm actually a hospitalist. And the thing is, emergency docs and hospitalists, as judged by our video, The Confrontation, they don't often see eye to eye, and there can be a lot of rudeness between them at our low points. And what I realized is when I did my emergency shifts as a resident at Stanford and trained, I immersed myself in that world so much, and I loved it, and I saw how hard it was to do what they do. And even the most complex cases, it's just impossible when you have so many patients to go through every perturbation. That's why you call medicine, right? Because you need the admission, or you need the help, or you need another set of eyes, because the guy in 5 is crashing, and there's a trauma in 2, and all this stuff is going down. When I viscerally knew that, and I knew that these were really good, funny, intelligent people that were trying their best to help human beings, it became very hard to be rude on the phone in the middle of the night when I'm woken up at 3 in the morning for an admission that was probably soft. Instead, I would try to be nice. Now, where that failed, I can still remember the times when it failed because I can count them on like 3 digits. And when it happened, I was tired, I was defensive, I'd had a bad day, someone was probably rude to me, I'd had 20 admissions or whatever, and that resident who called me from the emergency department used a tone of voice or a way of speaking that triggered me somehow, triggered my elephant to go, that's it, I've had all I can stand, I can't stand anymore. And I let it fly, right? And you could just hear the person wither on the other side of the phone, because I'm the attending physician, and it's the middle of the night. They already feel crappy about calling you at 2 in the morning, right? And it's the same with nurses. When nurses call doctors, when doctors call nurses, it's the same interaction. It's really the same. It's an interaction between colleagues and peers that it rapidly devolves into a hierarchical, crap fest where we're throwing feces like monkeys. And when I hung up that phone, I couldn't go back to sleep in the call room. I couldn't function because I was just reliving the interaction. First angry, because Elephant was in charge. Angry, angry, angry. How dare this person do this to me? How dare this person disrespect my training by trying to tell me how to do my job? How dare, how dare, how dare. Then guilt, regret, self-blame, shame, and then pick up the phone. Hey, could I speak to the resident who just called me? This is Dr. Damania. Yeah, hey, I'm really sorry for what I just did. I'm super tired. It was totally inappropriate. You did the right workup. These are the reasons I got upset. We'll take care of it. We'll come see the patient, et cetera. And the minute I made that call, I fell asleep instantly because all that shame and guilt and self-blame and anger dissipates. Being nice, okay, not artificially nice. We need to be blunt when we're blunt, but being clear and transparent is a huge benefit when we're trying to build what we're calling Health 3.0. I mean, do you have anything to add to those from stories that you've experienced? You were on both sides. You were in internal medicine, radiology.
Well, I think that did play an important part in my, revelation, which was that I had started as a medicine resident, and so I had been on the receiving end of rude radiology residents. And the problem with, I think, training is that everyone's just trying to block. When you're a medicine resident, you're trying to block admissions. When you are a radiology resident, at least at the time that I was training, you're trying to block studies. But really, that's really not supposed to be the goal. The goal is just doing the right thing for patients, but unfortunately, sometimes in training, that gets lost.
And I think segueing from this into the next idea, which is that rudeness affects team cohesion. So the study showed that teamwork kind of fell apart. And I want to rehash something because I've had a few requests. We haven't been talking much about Health 3.0 lately. We've kind of done shows that all relate to Health 3.0, but people have asked me, could you please just rehash? I know it feels repetitive for many, but just rehash. What is Health 3.0? How does it relate to the topic at hand, and how can we help build it using some of the information that we're talking about now? And again, and then we're going to go to comments and get your input on all this. So just to rehash, Health 1.0 was our old paternalistic 20th century system of healthcare where it was a doctor and a patient, or a nurse and a patient, or whoever and a patient in a paternalistic, one-sided but sacred relationship where we had time to take care of our patients. We had autonomy. Nobody told us what to do. We also didn't have a lot of evidence-based practice. We didn't have a lot of science. We didn't have a lot of technology. It was just about the art, the touch and the intuition and the stories, right? But the doc or the nurse, the caregiver was the boss. And Health 2.0 was a reaction to the failures of that, being profiteering, fraud, inconsistent quality because evidence-based stuff wasn't really a thing, and the fact that the internet came around and patients were like, you know what, I can get information, and when I ask questions, my doctor treats me like a dummy and doesn't want to empower me, and this is not okay because we don't accept this in any other sector of our lives. Why should we accept this in healthcare? And doctors regulate themselves. Why should we accept that in healthcare? And look how the doctors are treating the nurses and how the nurses are treating the CNAs, and look at the hierarchy, and this is not okay. So Health 2.0 came along. Health 2.0, simply put, is this idea that medicine should be treated like any other business, like a machine, like an assembly line process that can be optimized using technology and using Lean and Six Sigma and all these other processes. So we have EHRs, we have click boxes, we have managed care, we have multi-specialty groups coalescing out of individual autonomous practices. We have MBAs now supervising physicians and telling them how to practice, insurance companies supervising physicians and having the final say. And this is a vastly different world. There's a lot of good evidence-based medicine, best practices, technology. So even though we hate electronic health records, they actually can save lives when implemented correctly. It's just we're in the very early stages of it. So it's not the best game. We're burning out. We feel like commodities. We feel like numbers. Health 2.0 is killing doctors, nurses, pharmacists, everybody. Pharmacists, try working in a CVS for long enough, you will see Health 2.0 at its finest. So the question is, what's next? It's Health 3.0. Health 3.0 says yes and to 1 and 2. It says you're both correct but partial. What's going to emerge is bigger than the sum of its parts. Restore the human relationship and the autonomy of the caregivers. Use technology to leverage the human relationship and have our business guys seek to grow the pie instead of grab these little bits of fee-for-service pie, and get paid on actual outcomes. But key to that is working in teams, non-hierarchically. So doctors, nurses, health coaches, physician assistants, nurse practitioners, pharmacists, everybody working in a team That's the key. So how does this all, by the way, at this point, this is where my wife literally, yeah, she's done. She's like, how many times do I have to hear about Health 3.0? This made-up construct, which apparently was on Headline News. Apparently Headline News cited it. So this nomenclature is starting to catch on, guys, so we can transform the world. Sometimes words matter. 3.0 says we work in teams in service of outcomes for the patients. Technology leverages us, but we treat each patient as a unique. And that means that if rudeness triggers a failure of cohesion, if hierarchy in medicine and rudeness within our ranks, eating our young, et cetera, destroys team cohesion, then it has no place in Health 3.0. If we're going to build a better system, not just for patients, but for caregivers and for the economy as a whole and society as a whole, looking at individuals but also how they fit into populations, we have to work better as teams. That means the things that we're talking about today, which means rudeness. In other words, a statement put out into the world to try to hurt another person, whether it's out of fear, anxiety, anger, defensiveness, it doesn't matter, or hierarchically, has no place. But a question I have for you, does rudeness ever have a place? Does bluntness and rudeness have a place in healthcare, Mrs. Dogg?
Well, I actually personally don't think that you need to be rude to be direct. I think that if a patient's welfare is on the line, you certainly want to be direct and immediate. But that may be taken as being rude. But rudeness also, I feel like that has an overlay of really, trying to make someone feel bad about themselves or their knowledge or their abilities. But if you're just direct, trying to help a patient, then that's not really rude.
So I see like two scenarios. One is an attending physician on wards or a nurse teaching trainees hashes on a medical student or a trainee nurse so hard that they break into tears. Why didn't you order this test? That patient's dead now. Why didn't you order this test? Did you not consider ordering it? Did you consider this diagnosis, et cetera, et cetera, et cetera, et cetera? Now you could argue that's about patient safety, about teaching the medical student, but what's the effect? Medical student bursts into tears, confidence shattered, doesn't learn anything, is just terrified, has a recall bias now forever about this particular problem, over-manages it, over-treats it, over-recognizes it in the future, and it's a mess. Another option, you're in a code situation, someone does the wrong thing, patient's life is in danger. Hey, quit doing that right now, stop, you're making a huge mistake. Go do this, da-da-da-da-da. Afterwards, find that medical student or resident and say, hey, the reason I yelled at you was this and this and this. It has nothing personal to do with you. Here's the teaching point. I'm sorry if it came off as rude, but the patient's life was in danger and I wanted to make sure they were okay, so I hope you understand. That is another way to deal with a very similar acute situation, right? And that's a more 3.0 way to do it than a 1.0 paternalistic way, or a 2.0, oh, everybody's kind of right and we're just clicking the boxes.
So what do you think about, patients being rude to physicians or the other way around, physicians being rude to patients?
So this kind of thing happens all the time. Let's think about the physicians being rude to patients. How many times on a team, and I don't mean just physicians, we're talking about nurses too, everybody on a healthcare team, right? Administrators, I've seen it from all sides. How many times have we used the word gomer about a old person, get out of my ER, who is just straggling along and we feel like we're suffering having to take care of them? How many times have we used the phrase, hey, you can't cure stupid, pointing at someone whose behavior is leading to their chronic disease and they don't change no matter what? Now, these are some of the rudest things you can say to human beings, and I think the argument is that if we're doing that, we're projecting our own feelings of powerlessness and our frustration and our feeling that maybe the patient should be more accountable and all these kind of things, and we're using this kind of attack, this rudeness, as a way to make ourselves feel better. And it is not the best way to be a good, compassionate human being. It's not the best way to be a good teacher. It doesn't work. Now, when patients are rude to doctors, there's sort of two categories in my mind. There's the category where they're scared, they're overwhelmed, and they don't realize what they're doing, and they're just trying to feel a sense of control. And you can have a lot of compassion for that. But then they're the kind that where it's just part of their personality. Maybe it's a personality disorder. Maybe a lot of them are just nasty to everybody, and doctors see this pattern in patients. And it's hard. And in those situations, you can redirect, but it's going to be hard to cure that. So we have to figure out, how do we deal with our transference, our response to this rudeness as professionals, so that it doesn't affect us cognitively or behaviorally, and we don't lash out, we don't make mistakes, as the study suggests that we will do, even unconsciously. And so this is how I try to think about it. One of the things, it's interesting, rudeness within the medical hierarchy can lead to a tremendous amount of suffering and failure and burnout. So I get a lot of messages, private messages in Facebook from people, particularly people lower in the traditional medical hierarchy than, say, an attending physician. So it might be a medical student, it might be a nurse, it might be a CNA. And they say, Z-Dog, I don't know what to do. This doc yelled at me the other day and really made me feel like I was incompetent. Or this patient shouted at me and said that all these horrible things, and I've never been talked to that way in my life, and I just don't even know what to do. I feel so horrible, I feel useless, I feel terrible. You can see what it does to that person. It inflicts suffering not just on the victim of the rudeness, but on the person who's being rude, because their rudeness is a kind of a reflection of suffering. If they were happy and content and at peace, they wouldn't be rude. Like, rudeness is a kind of an anger, it's a defensive posture. It comes from a lot of times from fear. So I often tell people, listen, the key thing is we don't take this personally, and we try to imagine the person who's being rude not as an empathic way. In other words, we don't put ourselves in their shoes. We go, wow, they must really be suffering to be treating me this way. Like, imagine how much pain they must be going through, and I'm going to try to respond with love and equanimity, and it's very hard, and it takes practice. Sometimes you have to, and on Easter it's a good time to be reflective about this, right? If you look at anything that the great sages have said through time, it's about equanimity in the face of love thy enemies as if they're your neighbors, all these other things, the golden rule, etc. Should we read some comments? What do you think?
Sounds good.
You got any?
Oh.
Ah. Oh, I'll look at them too. I had a doctor yell at me during a code, says Danny Coach, because I refused to give a medication he handed me. I tried to say this is the wrong med, it was Benadryl, not Epi, and the doctor screamed and told me I suck at being a nurse and I never ever better refuse an order again. He said, if you don't give that med, you have no job. So I walked out and didn't give the medication. He tried to have me fired over and over. Danny, who's got the problem there, right? It's certainly not you. It's clearly the physician. And that physician, again, if you look at it as, imagine the suffering that that physician is feeling, that tightness in the chest and that anger, because there's something else going on that they're projecting. That's how I would look at that. And the best thing is to try to have a dialogue after the fact and say, you know, I don't think yelling helps me learn. If you think I did the wrong thing, teach me what I did wrong, and here's why I did what I did. But, you know, I understand you're upset and I see it, and I want to see if I can make it better. That will diffuse a lot of situations in a crazy way. And again, my wife kind of pointed out that niceness gets you a lot farther than rudeness. I have found this out in my life on every level. I try to go out of my way when I'm in, especially in medical settings, to be nice to everybody, to treat everybody as if they're the most important person on the team taking care of anybody. And it's amazing because then people behave like they are. They live up to the love and the expectation that you give them to do this. And this is the heart of Healthcare 3.0, is treating everybody like they're the most important person on the team with the patient at the center, but we're also part of a web that takes care of each other. And that, I think, is going to transform things if we can work on it. It can be cultivated. Even people with severe personality disorders, you can help cultivate this kind of compassion. Other comments. Let's see. Some need to think and behave more professionally, says Marta Rodriguez. I have nursing students in clinical feeling embarrassed due to doctors and nurses pushing them around while in clinicals, Marta Rodriguez. It's part of the culture of how we train, right? Don't you think we should change that? It seems like we're in this Greek hierarchical culture where it's like memorize facts, then kiss the ring for 2 years, or however long your training is, whether you're a nurse or a doctor or a pharmacist or a dietitian or a physical therapist, doesn't matter who you are. The culture is this hierarchical one, and it comes back from the old days, right? These sort of Greek Socratic days. And it's got to transform, it's got to change. Now, my wife and I probably have a similar experience watching the transition from Gen X residents, because we're both attending physicians at Stanford, supervising Gen X physicians to millennial physicians, and this idea that even expectations of training and degrees of ability to tolerate that kind of hierarchy have changed. I mean, do you agree?
The hierarchical change.
I mean, millennials, as you've seen them emerge on the wards, have you seen a change in like training expectations, the tolerance of abuse and things like that?
Well, I certainly think that now there's less tolerance for abuse. I mean, I think there was a big to-do about even whether pimping is an appropriate way of teaching quite a few years ago. Whereas I think when we were training, pimping was just the norm. And, you know, public humiliation was, the threat of public humiliation was a good motivator for studying.
So this is interesting because this is a generational thing. I have no doubt about it. And this is one of the greatest barriers to transforming into a more compassionate, team-based culture in our training and in our practice in healthcare. And when I even think about it, right? Pimping, by the way, for those who don't know, is a way of aggressively asking questions on rounds as a way to kind of quickly get answers, and if you don't get them, to humiliate and shame somebody into studying harder the next time, as my wife was saying. So the trick with this is it is a very hierarchical, very militaristic, kind of Greek way of doing things. And the minute I think about millennials trying to push back on this, my elephant gets angry, because my elephant was conditioned by pimping. It was conditioned to be pimped, it was conditioned to pimp, and I suffered, therefore they should suffer. And then after taking a space, taking a breath, seeing this response, this is the great thing about consistently meditating, is you can actually have a space between what your elephant believes instantly and your response to it. I go, oh wow, I am that guy. I am the guy that I swore I would never be. The attending physician who was like, I walked uphill both ways in the snow, and therefore you should too. And here's what I've actually found in our millennial residents. They're super sharp, they're optimistic, they're idealistic. Yes, they have a slightly different work ethic because they were raised differently with different comforts and maybe different levels of privilege, and maybe there's participation trophies. But the truth is, they care deeply about their craft. They want to learn, but they want to do it in a sustainable way that is something that is balanced. And that's why a lot of them are leaving clinical practice, because they don't see it. They see the same hierarchical crap that all of us went through, and it didn't do us any good at all. Now, some would say like everything from work hour rules to on and on and on kind of relate to this idea, but it all wraps back to this idea of treating each other compassionately. Do we decide to do it as an institution and as individuals, or do we let it slide? And that's the question.
And I think actually, just going back to the pimping, there was one of my best mentors, when she would pimp, and of course we wouldn't necessarily know the answer, she would always start her answer with, well, as you know, and then she would give us the answer. And in the back of our heads we're thinking, wow, we really didn't know that. But she told us the answer in such a great way by conveying the information and teaching us without making us feel like we were dummies. That she really was one of the best teachers I ever had.
And, you know, and recognizing those great teachers and modeling on them is fantastic. I think one of the big downsides, so people often ask me, oh, does it matter where you train? You know, like, does it matter what medical school you went to? Does it matter where you went to residency, really? And I always think, like, and maybe my wife agrees with this, maybe she doesn't. I don't think we've talked about this. I always felt like Stanford was a bit of you got out of it what you put into it. And there were people there that were totally incompetent, and there were people there that were amazing. And the name Stanford meant nothing. But the thing that Stanford offered that maybe other programs may not have was incredible mentors, where you looked at them and you modeled on them, like your mentor, like several of my mentors, and you just said, that is just a darn good doc that I want to be like when I grow up. And it's about that. It's about that compassionate mentorship. And, you know, pimping and rudeness and all that aside, it's about finding those mentors. And I found when I've toured through and I've rounded at institutions that maybe don't have that cachet of name, there are still amazing mentors there. And the people who are lucky enough to get the rotation with them tend to get really good training. And the people who aren't, who get maybe the community doc who's burnt out, who doesn't care, who's going through the paces to get that adjunct clinical faculty status, and this is true in nursing too, they are getting the short end of the stick. Not through any lack of effort on their own, it's through lack of mentorship. And so it's a tragedy. We need to figure out, how do you increase great mentors and good teaching and compassionate transfer of wisdom? Not knowledge, wisdom. How do you treat patients? Most of what we are taught is wrong. It's just wrong. It's going to be shown later that we're barbarians. So it's a question of, how do you take care of patients? How do you interact with patients? How do you think about a problem? How do you use critical thinking? That's the stuff that matters. Let's read some more comments here. Philip Saltis, ER doc for 30 years. Thank you for your service, Phil. Can't count the number of times I got bitched at for awakening an on-call doc for either a consult or for them to see the patient. You learn to just ignore the complaints and focus on the patients. So Philip, what I've noticed is the best emergency docs can tune that ish out. They do not take it personally. They see it as background noise. They've worked on it for years. And if they let it get to them, they would not function. And I find the newer ones that are just starting out, they're more affected by it, and they're more prone to the problems that would come with that negative interaction, right? But we can do a lot better, guys. You know, look, if I can be nice on the phone and I talk to my wife, I am a jerk. Any chance I can get. She's nodding for the people on the podcast. Any chance I can get. And if I can go out of my way to try to hold it together, right, and I've only failed a handful of times, that says that anybody can do it, seriously.
And I really think that mentors really set the tone for everybody, because I think that when you're nice, when you're kind to people, when you teach people without putting them down, you know, everybody really does better. And I think actually everyone is happier for that. And so I think it's a really important part that mentors play and leaders play.
Yeah, I mean, I think that's spot on. As much as I hate to agree with my wife on anything because it makes me feel weak and incompetent, she's absolutely right. Jeff Hughes says, work for a large radiology practice in Austin. 90% of our raids were great, but there were some real a-holes. I remember some a-holes in your class, Mrs. Dogg, because remember, I was doing medicine while your residents were training. And I remember there were a couple that I could name, which I won't, who were just nasty, rude, blocky, folks. I mean, did you get that sense within your class that people like that existed, or was it more you had to be outside and experience it?
You know, I definitely knew people who made the person on the other end of the phone cry because they were just so mean, trying to block studies and essentially making the person on the other end feel like they were complete idiots. And you know, it's unfortunately it was just sort of the culture that we trained in, and it was really very unfortunate because outside of that they were nice people, but you know, in that kind of situation, it seemed like just the ugliness really came out.
I mean, I think this is true across different training programs. You're considered strong if you're a wall, if you block admissions, if you push back, and it's true, I think, in nursing too, if you push back, if you're, you know, these are considered positive traits in our hierarchical medical culture. So within the program, you're beloved. Outside of the program, people think you're an ass. And I think this has got to kind of change. It's hard because, especially in radiology, Liz Mangieri had asked, radiology is a bully field? I'm very surprised. How does this happen? Did it happen to you, Mrs. Dogg? So we talked earlier about how it had happened early on. And because you guys work really hard, contrary to popular belief, radiologists don't sit around just, you know, sailing their yachts. Believe me, I know this.
I'm still waiting for my yacht.
Yes, as am I. As am I. Remember the bargain we made where I said, hey, I'll tell you what, I'll become a hospitalist, I'll work for a few years, you can go retrain in radiology for 4 more years and do what you're passionate about and follow your dreams and be your little Hannah Montana idealistic self.
Okay, but see, now I'm in Vegas, okay? Not doing that. And you're doing this.
I'm telling you, karma is a bitch. It is a very, very difficult. When the karma circle comes yin and yang, it comes around.
It's going to come back to you.
Oh God, no. I don't want, or no. Some more comments.
Well, to go back to Liz's comment as to why radiology would block, I don't think that, I'm not sure that that's actually so prevalent anymore. I think that at the time that we were training, as I said, we were a single resident covering 3 hospitals. And so at that time, we didn't even have an ultrasound tech on call. And so if anyone wanted an ultrasound, basically you would have to stop everything else, sometimes you'd have to get the patient yourself, bring them over to the ultrasound suite, do the scanning, and all that time that you're doing the ultrasound, you know, there would be studies that would be piling up of some acute patients. And so you wanted to kind of push off anything that really didn't sound acute. And so it wasn't for any, you know, wanting to just
hurt
not
people.
do work, but it's just, you had to prioritize.
Well, you know, and I think that kind of pushback you have to do, it's kind of a survival triage thing. There's just probably good ways and bad ways to do it. And as a hospitalist, I had to do it often, you know, inappropriate admissions, et cetera, because we were just getting overloaded. And if you get a BS admission that can be treated as an outpatient, you really have to push back, but you can do it in a way that makes the consultant feel empowered instead of feeling belittled. That's a key component of it. You always want to empower, and that's my philosophy as a hospitalist when I was practicing at Stanford was yes, yes, and. Yes, you're right, and here's the thing that we can also do that will keep them an outpatient and they don't need to be admitted, right?
I definitely think that even with radiology, the ordering of certain studies should be collaborative with the ordering physician. So, I don't really think that radiologists necessarily should say, I don't think this patient needs the study, because the radiologist is not sitting in front of the patient and evaluating the patient the same way that, for example, the ER physician is or the internist is. But certainly you can talk and decide, what the next appropriate study is.
Well, and I think also so getting back to Health 3.0, having a radiologist who's integrated as part of a team where we know each other, where we can go and talk to them in person instead of sending each other love notes through Epic, which is bullish, guys. Like that, these electronic silos break down human communication into little snippets that don't work the same way. You can't get the emotional tone, you can't get the nuance, and you can't have the discussions. One of the greatest experiences always when I was rounding with my team at Stanford was going into radiology and talking to the radiologist, including your mentor, who was great about stopping everything and spending time to teach us dumb internists how to interpret this film, how to better order in the future, how to collaborate with the radiologist, how to give a history that's meaningful to the radiologist so they can use their considerable expertise to help guide us. And I think that's a key thing. By the way, chime in right now if you want Mrs. Dog to come back on the show and do Radiology for Dummies, because I think it would be tremendous. We could get one of those millennials in here to actually pull up the slides and she could go through some studies. One thing I wanted to ask you, Mrs. Dog, is I get a lot of messages from radiology techs, CT techs, ultrasound techs, x-ray techs, who want some respect. They feel like they're an important part of the team, that they're misunderstood, that they do a lot of hard work that isn't appreciated. What's your take on the techs?
Well, of course I love my techs. They do a lot of work. They have to get the patient, get them on the scanner or whatever they're doing. They have to, it's even a mystery to me, all the things that they're doing. And they have a lot of technical knowledge. And so I rely a lot on my techs to get me the images I need, whether it's ultrasound or CT or X-ray. You're all awesome. And I'm often calling during my regular job to get more images, and they're always very helpful.
That is the correct answer, and now they will not be angry with me, which is good. Now, I'd missed the comment. Did you see any other comments you want to read there? I saw a comment that I wanted to read, and it disappeared. It was a nice way to wrap it up, but it basically said, I don't remember who it was, but it said, what this gentleman had noticed is that the good moments, these positive interactions, he seems to notice are increasing in length and in duration and in intensity, and the bad moments, the negative interactions, are decreasing. Now, some will disagree with this and say we're getting coarser and more vulgar and more rude as a medical hierarchy. But what I think he's noticing is something I've seen, which is the desire and the natural evolution of medicine to go 1.0, 2.0, and more true, more inclusive, more betterer, for lack of a better term, 3.0. And 3.0 is more compassionate, less rude, more all-encompassing, and more true. And I think we're going to get there together if we work hard to build it. And it sounds really naive, but I think it's actually happening and people are seeing it. And I know other people are suffering. But these are the sort of difficulties we go through before we emerge into the next stage. So be patient, be strong, lead by example, be nice to people. Compassion greater than empathy. That's all I got. You got anything?
No.
I want to thank Mrs. Dog for stepping out of the shell. This is an introvert, people.
I'm going to have to go lay down for like 10 hours now, close in a dark room.
Is that really true? Do you get exhausted doing extrovert stuff?
I do actually get a little exhausted, but I actually don't have to lay in a dark room.
Yeah, it's true.
But I do for my job.
Yeah, no, dark room all day. No, introvert, extrovert, I get energized by this sort of thing, but then I get exhausted. She just gets exhausted. So thanks to Mrs. Dog. Thanks to you guys. Our podcast is doing awesome. Go to iTunes, subscribe. If you don't go to iTunes, woo, there goes the mic. Technical difficulties. Subscribe. If you don't have an Apple device, you can get it through soundcloud.com/ZDoggMD. Please review our podcast. Share this with everybody you can and join the movement because it's against medical advice, snitches, and we out. Can you hit that little button on there that, bye-bye, guys.